the scheduled time. It's a great pleasure to introduce this session where we're going to be looking at the impact of guidelines on our practice in the UK and how our practice complies or differs from that. It's a great pleasure to be with my colleague Francesca Montorsi here from Milan. And as you can see, we've got a very varied programme with excellent speakers, so it's going to be a real feast of information. Without more ado, I'd like to call upon Asif Mania, who's going to talk about priapism. Asif, as you know, works at UCL, and so welcome again. You spoke earlier, I saw. I was there.
Thank you very much, Chris. I'm going to go over the main guidelines that we have as a urological resource, and currently there are the AUA guidelines, the EAU guidelines which were recently published, and there's development of some BAUS guidelines as well. When it comes to guidelines, what we really have to consider is what level of evidence are we using, what's the search criteria, or are they just a consensus statement or a panel of experts? The other thing that I was looking at with regards to these guidelines is how updated are they? How regularly do they get updated? But the most important thing is, can these guidelines be useful for our practice here in the UK? We've got a different healthcare system, and we have subspecialist units whereby in Europe and America they don't. And can we use the same guidelines in our day-to-day practice here? The other thing about guidelines is that they are useful as a medical legal resource as well. So if there are going to be any negligence cases, you can refer to the guidelines. But what I wanted to just give you an overview of was what's contained in these guidelines for priapism, and what the difficulty is with regards to developing guidelines for a subject like priapism. So, first of all, priapism is a rare emergency. We'll see, a couple of cases a year, and therefore most of the guidelines are based on case series, case reports, or personal series. We can't really randomise treatment options for priapism because it's an emergency. You have to deal with it according to best practice. And the key thing is that the outcome will change according to how long the priapism has been there for. And one of the key things about guidelines is identifying what to do when for these individuals. So first of all, the AUA guidelines were developed in 2003, and it was an expert panel that convened and proposed these guidelines. And what they did was use a search criteria going back to 1966. Now, in 2010, they've looked at the guidelines again, but there hasn't really been much of a change from the original ones in 2003. In contrast, the EAU ones are a little bit more substantial. They use a search criteria up to January 2013 and eventually published them in 2014. And they've used the Oxford Centre for Evidence-Based Medicine as the grading system with regards to the level of evidence. So, with regards to the definition of priapism, we'll all accept that a priapism is a penile erection which is prolonged and it stays there despite orgasm and in the absence of sexual stimulation. And we tend to use this 4-hour time limit. Now, this is fairly arbitrary, but we need to give a time limit. So, if you look at the guidelines, they will subdivide them into ischemic, non-ischemic or stuttering priapism. I'm really going to focus on the first two. And out of those, with the non-ischemic, or what we used to call high-flow priapism, I think the management is fairly straightforward, so we don't need to dwell on it for too long, but it really involves making an accurate diagnosis, initially trying conservative treatment, and then going on to arteriography and superselective embolization. And if that fails, you may want to contemplate surgery for the very prolonged cases which are going on for months and months and haven't gone down. But the most important one, I think, out of all the three subtypes is ischemic priapism, because that's got the most devastating consequences in terms of erectile dysfunction and corpus cavernosum fibrosis. Now, when you look at the guidelines, you can see that in the AUA guidelines, they don't actually give a time limit. They just describe it as a prolonged erection, whereas the EAU guidelines do state there's a 4-hour time limit for a priapism. For the terminology, both of them use ischemic priapism now rather than saying low flow. It just avoids that confusion when you talk about low flow, high flow priapism. But in the EAU guidelines, they talk about arterial priapism, indicating the high flow or the non-ischemic subtype. And when it comes to treatment, the AUA guidelines will state that you've got to aspirate and give them an alpha agonist, whereas the EAU guidelines will state that you can just aspirate initially, particularly with the short-lived ones, because you've got a good chance that you'll be able to reverse it. And in terms of the medication that you're going to use for the alpha agonists, again, not much variation apart from there's metaraminol used in the AUA guidelines, and the EAU guidelines do mention methylene blue, but it's not really used in UK practice and is really based on some selective case reports. So when you look at these individuals, everyone does well if you can get the priapism down with aspirating blood from the penis. You may want to give them an alpha agonist, and in our UK practice, the most commonest one that we do is give phenylephrine. But the problem really lies in terms of what we do when the penis fails to DHMS. What happens despite all of these interventions, the priapism still persists? Well, we tend to sort of talk about surgical shunts, but if they fail, you're inevitably going to develop fibrosis and eventually erectile dysfunction. So if you look at a time-adapted approach and divide it up into 3 phases. So if you've got a priapism, say for instance, up to 24 hours, you're more than likely going to get it down with aspiration and phenylephrine. The sort of grey area is really 24 to 72 hours. What do you do over here? Because some of them will go down, some of them won't go down, but long term, what you tend to find is that a lot of patients will develop erectile dysfunction anyway. And then the ones which are over 72 hours, I think there's no debate about those. If you've got a priapism lasting 3 days or more, you're inevitably going to develop erectile dysfunction and require a prosthesis. So really, the grey area is here. So what do the guidelines do to address that grey area? Well, they all talk about making a clinical diagnosis, doing a blood gas analysis, ensuring that you've got hypoxic blood, and it's acidotic in terms of pH, and also performing some kind of imaging as well. Now, both the guidelines will say that you should use penile duplex, and the EAU specifically mentioned that you should do that before you aspirate from the penis to ensure you don't get any aberrant high flow. Arteriography is mentioned as well, and it's only the EAU guidelines that mention MRI of the penis. Now, in our own practice, MRI is fairly useful, and you can see over here that if you've got someone who's been given gadolinium, there's no enhancement, and that's quite a good indication that the smooth muscle has undergone necrosis, and I mean, these patients aren't really going to recover. So it is useful in certain circumstances, but I think in most cases a penile Doppler is adequate. You can go to an MRI in those more problematic cases. So do the guidelines really help us when patients fail to respond to your aspiration and alpha agonists? You can go into shunt surgery. So remember this grey area, 24 to 72 hours. What do you do in that situation? And I think a lot of the shunts are fairly historical. I mean, they've been described several years ago. They're still used in your day-to-day practice. And both guidelines mention distal shunts and also proximal shunts. But what is the long-term outcome from these? Now, for those of you who don't normally perform these, that's just a distal shunt, just a true cut going in through the glands into the distal corporal tips. Here you can see an open window being performed between the glands and the tunica albuginea being excised. And that's the proximal shunt, just between the corpora and the corpus spongiosum. But they are just effectively glorified drainage when the priapism has been there for too long. It may cause detumescence, but what happens long term? There's also some simpler shunts, which I think most urologists in whichever practice they have in a DGH setting should be able to perform one of these, and the simplest is just putting in a blade into the glands, into distal corporal tip and rotating it 90 degrees, just withdrawing it. So at least you've done a shunt. Because one of the problems that we find is, in the absence of any definitive guidelines, is patients are managed with aspiration and then left, or they're trying to refer, it causes more of a delay. And then several years on, when it becomes a medical legal case, they get asked, well, did you have a shunt? And I think it's fairly straightforward for most urologists in practice to do this, to at least do a shunt. And I think that's probably the minimum standard, if we are going to develop guidelines here in the UK, that we should advocate. So when we look at the T-shunt procedure in these individuals, you can see that even if your T-shunt is performed within 24 hours, in this case series here, the ED rate was still just over 50%. If it's performed at 48 hours, they all develop erectile dysfunction. And the reason for that is, when you look at the corpus cavernosum smooth muscle and look at the DNA fragmentation, as the degree of ischemia increases, as the duration of ischemia increases, you get more DNA fragmentation, you get more smooth muscle necrosis, and that's irreversible. When smooth muscle dies, you're not going to be able to reverse that. You're just going to replace that with fibrotic tissue and eventually develop ED. So, just moving on to surgical interventions, the only sort of guideline that really mentions the use of an early penile prosthesis is the EAU guidelines, and what they state is that if after 36 hours you've done your conventional treatment, which involves corporal blood aspiration, phenylephrine, it fails to DHMS, you may want to consider an early penile prosthesis, and they give that a grade B recommendation. However, in the AUA guidelines, there's nothing really about refractory cases. There's no mention about what you do with those. So if you look at our series of 50 patients who have undergone an immediate penile prosthesis with a follow-up of just over a year, satisfaction rate is 96%, which is a lot higher than those who are left without having a prosthesis and given a delayed prosthesis. On a technical aspect, delayed prosthesis, you can see over here, requires complete degloving of the penis, multiple corporotomies. You've got a risk of injury to the urethra, perforations. You also have to put in a smaller, narrow-based implant, possibly a shorter one. There's all kinds of problems, and you can see why they're more dissatisfied. So when it comes to guideline development for the UK, there is BAUS priapism guidelines to reflect UK practice, which are going to be developed. And what one of the key things here is going to be to identify specialist centres where these refractory cases can go and undergo more specialist imaging, or even consider having an acute implant being placed. But I think as a minimum standard, most people around the 24 to 72 hour mark should be managed adequately in your DGH or a teaching hospital which hasn't got a specialist unit, because the corporal blood aspiration, phenylephrine is all fairly straightforward, and I think a distal shunt as a minimum will mean that you've probably done as much as you can in that particular centre. The key thing really is defining these time points. Are we going to use a 36-hour time point where you're going to consider a prosthesis? I think this is going to be open to debate. But without doubt, I think over 72 hours, there's going to be a clear indication that you could just biopsy to prove necrosis and then offer them an early implant. Now, this was all controversial several years ago, but we've started to look at the outcomes from these. And we're also probably going to develop a list of what we'd classify as complex cases for priapism. So these are the ones which are not going down, the non-ischemic ones which require embolization or not going down after failed embolization, pediatric cases, again, not much in the way of guidelines there, and also malignant priapism. It's an algorithm that was published last year, which will probably form the basis for these guidelines. You can see over here that, again, if it's short duration, you want to do aspiration drugs, a T-shunt. If it's longer, you're going to start recommending a penile implant. The one thing that we're going to have to debate is what do you do in the group in between. So if we use this new time-adapted approach, what we'll be able to do is identify what to do when the patients come in based on the duration of priapism. Now, a lot of the time, it's not always clear-cut how long the priapism has been there. People wake up with it, you don't know how many hours they've had it while they were asleep. It's normally the pain that wakes them up. So although they might end up in A&E 4 hours later, they could have had it for 8-9 hours, which is why there's always this grey area. There's also no definite time point. You're not going to be able to say that at 24 hours, actually, the smooth muscle is dead. Within 24 hours, it's still alive, and you should have been treated within 24 hours. So again, something that lawyers tend to use, but all this is fairly arbitrary. So like I said, so all units should be able to offer this, and if there's failure of detumescence, there should be regional units that you can refer to who can offer penile MRI biopsy and a penile prosthesis. So just to conclude, I think we need to remember that guidelines are just guidelines. However, we need to try and adapt them to reflect what we do in our own healthcare system. Seeing that we've got a free healthcare system here, we need to ensure that the health economics is available. And for priapism, I think on the whole, looking at what's out there at the moment with guidelines, we do need our own national guidelines. Thank you very much.
That's it. I think we've had our time, I fear. So thanks very much indeed.
So the next speaker is Mr. Roland Rees, who is going to discuss for us the penile curvature guidelines. Roland, if you can stay within 12 minutes for your presentations, like agreed, so then we can take some questions. Thank you very much.
Thank you. So, Peyronie's disease, how are we doing in terms of the guidelines in the UK? One of the problems, as you probably all well know, with Peyronie's disease is, in terms of comparing it, looking at treatments and comparing studies, is the natural history of the problem. It's an evolving condition, it changes, and of course it depends exactly on which time point you see the patients as to what will happen to them in the subsequent 6 months or a year. There's also problems in comparing studies, in that some studies will have a mean presentation time of, let's say, 6 months, others might be 9 months, so your subsequent natural history will depend on when patients are being seen. And also there's lots of studies out there with no placebo arm, maybe comparing one oral therapy versus the other, and the all-important placebo is missing. And just to remind you of the natural history, here's a recent paper looking at 176 men with a mean curvature of 42 degrees, presenting at an average of 9 months presentation, and about 12% of them improve in the subsequent year, and approximately 20% of them are going to get worse in the subsequent year. So we have to bear that in mind at all times when we're treating this condition. So back to the guidelines. So what I've done is I've looked at primarily the European guidelines as they pertain to us most appropriately, and then also some more recent AUA guidelines. Also looked at some of the UK activity. HES is not particularly good at capturing Peyronie's disease. The diagnostic code, that is, it's termed indurato plastica penis, and I don't think any of the coders know what that is. So there were 5 cases of Peyronie's in the UK last year, according to HES. And we know that's not the case. With the procedures code, that's slightly better, and I think that's probably a bit, if you look at the over 18s, there were 735 corporal plications last year, which probably is a bit more accurate, but yes, we've got to be careful when we're looking at HES figures. And then graft the penis, some of those obviously will be incisions and grafting for Peyronie's disease, some of them may not be, some of them may be grafting for other reasons. The other thing that's recorded and has its own code on HES is the shockwave therapy, and as you can see there's still some 500 cases of shockwave therapy to the penis going on in the UK in the last year, although some of those may be for erectile dysfunction. The other thing of interest, you can get lots of data from HES, and again, caution with these figures, but we can look at readmission rates, length of stay, etc. And there's an interesting graph here showing length of stay is inversely proportional to the volume of corporal plications taking place, and it just tends to take off at around about 20 cases a year. and that maybe is of interest as we move into the future. So what have I done? So I've polled 16 what I perceived as being reasonably regular Peyronie's specialists or urologists in the UK, higher volume surgeons who very kindly got back to me very promptly on a short time scale with the answers to 10 pertinent questions, and those questions were in the area of how do you evaluate Peyronie's disease, what medical therapies do you use, what mechanical and injectable therapies do you use, and how do you tackle the area of surgery. So first of all, in evaluating patients with Peyronie's, the guidelines, these are the European guidelines, probably state the obvious. We've got to take a history and examine the patient. So you need to examine the lesion, make sure it's not anything other than Peyronie's disease. They also make reference to making sure you measure the penile length, and recording that for obvious reasons. Not only does the condition affect it, but the treatment can affect it. The patient's perception is often an exaggerated one, and men who often have treatment will perceive that the shortening is actually greater than what the objective measurements are. So from a medical legal point of view as well, it's advisable, according to the guidelines, to document that. Then in terms of assessing the curvature, I know there's mixed opinions on whether you do a drawing or take photographs or do an intracavernosal injection, but in the EAU guidelines, self-photography is an acceptable method. They advise against ultrasound of the lesion, doesn't really add anything, but they do mention that duplex ultrasound is appropriate and indicated in men with Peyronie's disease and erectile dysfunction. In the American guidelines, they talk about doing an intracavernosal injection in the clinic with or without Doppler ultrasound. So what did we do in the UK? Well, not so good with this one. 7 people out of 16 routinely measuring penile length, 6 not at all, and then 2 people using it discretionary, depending on whether they feel there's problems ahead. Certainly the men presenting, for instance, wanting a loo procedure where they don't really need one, raise suspicions because they're maybe overly concerned about penile length. And another colleague of ours only measuring it if they feel the penis is short. In terms of how do we routinely assess the curvature, this is pretty standard, I think, in the UK by the looks of it. So 13 out of 16 using photography, usually 1 from above, 1 from the side, and then record. What I do is I look at the pictures and draw into the notes so that there's a record in the notes. And 2 people routinely using injection therapy, but clearly that's a little bit more resource heavy and a bit more painful. You do sometimes photos are not satisfactory. You've got to make sure that the patient's got a full erection at the time. You may want to ask them that. If not, and if there's doubt, I think it's probably advisable then to move on to intracavernosal injections in the clinic. Not very many people using Doppler ultrasound in the UK. Presumably that's a resource issue. Some people, 2 people using it selectively when there's erectile dysfunction. But I'm not entirely sure as to what that really adds to the decision-making process. Okay, so what about medical therapy? So in summary, no drug has been approved by the European Medical Association for the use in Peyronie's disease, and only Protaba has been classified as possibly effective by the US FDA. EAU guidelines do mention Protaba as being the word may comes into these guidelines a lot, possibly reflecting the natural history and the confidence levels with treatment in Peyronie's disease. But this treatment may be effective. The word may features in almost every section of the guidelines, but essentially Protaba is the only oral therapy mentioned, and they go so far as to recommend against using vitamin E and tamoxifen in the American guidelines. And again, there is no level 1 evidence that there's any medical therapy that can intervene in this condition. Some medications helping with pain. Protaba, there was in the control group, in the placebo group, there was a worsening in the curvature, whereas in the Petaba group, the treatment arm, there was it arrested the deterioration, but there wasn't actually an improvement in the curvature. And bearing in mind that most patients come along to our clinics with a curvature that they want to see improving, this is not a drug you can really say to them, this will sort your problem out. Note on pentoxifylline, which there was some data on. This has come out since the guidelines. This is a retraction statement in the BJUI earlier this year, stating some statistical irregularities with the pentoxifylline data. So that again is not really something with a strong evidence base. So what do we do in the UK? Well, again, quite a bit of variation. 7 people using vitamin E regularly, 4 offering no medical therapy, 2 clinicians using Petaba, plus a few others using that as second line to vitamin E, a couple using phosphodiesterase inhibitors, although as we know, a lot of these patients have got erectile dysfunction anyway, and one using a combination of tamoxifen and pentoxifylline. What about injectable and mechanical therapies? Well, the EAU guidelines state that there's some grade C and B evidence in favour of verapamil and collagenase and interferon injections, as well as traction and vacuum therapy, again, may help. In the UK, nobody's using, none of the 16 people I asked is using verapamil or interferon injections. 9, so the popular answer here was a vacuum erection device. That's obviously gained a lot of ground the last few years. It's cheap. There are no side effects in particular, particularly when it's used as an exercise for short periods. 4 people not offering any treatment at all along these lines. 2 people using a penile extender, which has to be applied for many hours a day. Not sure how practical that is. And 1 so far using a combination of collagenase and vacuum erection device therapy. A word on collagenase. I think you saw this slide or a variation of it this morning. I suppose there's a new kid on the block, the IMPRESS study, looking at a protocol of 8 injections of collagenase or Xiapex into the plaque, sort of 4 pairs of injections followed by moulding or stretching of the plaque, and then moulding by the patient. And at the end of all of that, they mean improvement in curvature of 17 degrees. So we'll see where that goes. But as you heard this morning, again, it's more effective in the milder end of the scale in terms of curvatures. So shockwave therapy, the guidelines, the European guidelines and the American guidelines warn against using shockwave therapy for treating penile curvatures. There may be a room for using it in pain, but not for the curvature. It's an ineffective therapy. And I'm glad to tell you that 12 people are not offering it at all of the 16 polled, and 2 are offering it only where there's intractable pain. And therefore that raises the question, why are we picking up 500 cases of this treatment on HES? I think maybe there are some units still using this for Peyronie's disease, but essentially it's a waste of money if you look at the data. And maybe some people are using it for erectile dysfunction, because that's something that's been pushed from a commercial point of view recently. What about timing of surgery? So if these patients need an operation, when do you operate on them? The EAU guidelines say that you should either have stability for 3 months, stability in terms of the curvature, or there should be a 1 year since the onset of their symptoms. The AUA merely state that the presence of stable disease, which is a little bit more vague. So how do we do on this front? Well, 5 people sticking to the 1 year cutoff, including myself. 3 people using a slightly longer cutoff of 18 months. A couple using 9 months. Certainly in NHS, with a 3 or 4 month waiting list. I think what I actually do is see them at 9 months, put them on the list, by which time the operation comes round, they will have done their year. But remember that if you see them at 9 months, like the study I showed you earlier, a proportion will progress subsequently. Therefore, altering your outcomes from surgery potentially. Some people using 3 months of stability, 6 months of stability, 5 months, and one just operating when the patient thinks that things are stable and the pain has gone. So quite a bit of variation there. In terms of choice of operation, when do we do a shortening or a Nesbitt procedure, and when do we do a Lou procedure? I think that's one of the bigger questions for us as surgeons. The guidelines are relatively clear to use a 60-degree cutoff, and if you're going to do a shortening procedure, then they have to have adequate length to lose a couple of centimetres. And obviously they should not have any special deformities like hourglass deformities, waist deformities, etc. When do you graft patients? Well, you're probably all aware they need to have tip-top erectile function for a start, and on top of that, a severe curvature of over 60 degrees, no adequate penile length possibly, and complex deformities, again, if they've got good erectile function. What are we doing in the UK? Well, in terms of going back a second slide again, in terms of the guidelines, it says here, interestingly, especially plication techniques for the Nesbitt procedure, but it doesn't go any further than that in terms of comparing things. But essentially, the majority are using a traditional Nesbitt excision, 4 are plicating, 3 are doing a variation on the Nesbitt procedure, either removing part of the thickness of the tunica or drawing a couple of parallel lines and burying the tunica, and 2 people are using the 16-dot Lou technique, which is again a type of plication. In terms of when do we do grafting procedures, a bit of a spread here in the answers as well. 5 people using the 60-degree cutoff, 5 people not really. In fact, 9 out of the 16 people I asked don't routinely offer incision and grafting. Interestingly, some people are sort of more tailoring it to the patient, particularly around their anxieties regarding length, etc. And of course, some people just quoted that they would be interested in looking at the erectile function, and then others looking at the residual lengths. If you're going to do a Nesbitt procedure, if that leads to a particularly short penis, then they would think about a Lou procedure instead. What types of grafts are we using? Again, a spread. Some using bovine pericardium, pelvical, vein, biocore, which is the porcine heart valve material. But again, no real consistency there, except to say that vein seems to be going out of fashion a little bit, whereas many years ago, I think most people were using vein. In terms of penile implants, it's quite clear really that the indications for prostheses in Peyronie's disease are in those men who have erectile dysfunction, particularly erectile dysfunction that's resistant to oral or simple therapies. And both sets of guidelines are fairly consistent on that. And as our UK urologists, I think most people recognise that implants are indicated where the ED is severe or where there is a severe deformity. Also, if there's previous surgery that's failed, so for instance, you've done a Nesbitt procedure and they've now got erectile dysfunction and perhaps some more scar tissue, that further tunical operations are probably hiding to nothing. And then the other problem, of course, we've got in the UK at the moment is funding for these implants. Hopefully will change in years to come. So in summary, what we're good at is that we are particularly good at, in terms of abiding with the EAU guidelines in assessing the curvature in the appropriate use of investigations using mechanical devices. We're no longer using shock waves. We're pretty familiar with the cutoffs for when to do which operation. But there's probably room for improvement in that we all need to be probably recording and measuring the penile length and writing it in the notes. We are not particularly consistent or evidence-based when it comes to the medical therapy of Peyronie's disease. We're not using many injectable agents, but that may change. We've all got slightly variable cutoffs for surgery, and it's probably the guidelines are quite clear that either 3 months or 1 year since the onset of symptoms. And there's also a variation in the types of operations we do, although that's not stipulated clearly in the guidelines. So food for thought.
We have time for one or two very short questions. Sachs?
Two very quick questions. One is the 60 degrees curvature. Where does that come from? And what's the evidence base for that? Because I find that very difficult to find.
Yeah. Well, there was a paper, wasn't there, by David Ralph originally looking at tunicle shortening procedures using the 60-degree cutoff, I think, whereby very, very few people having tunicle shortening less than 60 degrees actually ran into trouble, although they were all being shortened. I think it was 3% of them had difficulties with intercourse as a result. You're right, where does the... I mean, for instance, there was an answer there, and something I do sometimes is a limited Nesbitt procedure. So somebody comes in with a 70-degree curve, let's say, and we have a rational discussion. I don't want a graft. I don't want to do a graft on them. And I say, well, actually, we'll placate it to 20 degrees, which is functionally straight. They can, you know.
Okay, and then the second question relates to what Francesco was saying this morning about the Lou procedure. It's interesting, isn't it, that Tom Lou doesn't do the Lou procedure anymore. Rather telling. And I think one of the points I think Francesco was making this morning is in terms of patient-reported outcome measures long-term, which are very poorly documented. And one of the issues there is, in a sense, one of the problems with these guidelines is advocating a procedure where we don't know what the long-term follow-up or outcome of these patients are. And if you look at some series of patients, 50% ED reported rates, poor outcomes at 5 years of follow-up. And I think this is the kind of data that I think is more meaningful. So I think that one of the areas of criticism I would have of these guidelines is they haven't taken into the long-term outcome measures of these patients, and it's trying to define those and trying to capture that data as well.
Yeah, I mean, I think it's a very valid point, isn't it? I think 2 points. One is we do a lot of operations that don't have 10-year outcome data in all sorts of parts of urology. The second thing is when faced with a patient in the UK, you say to them, look, Lou procedure versus penile prosthesis, a lot of them won't want an implant. And furthermore, a lot of them won't get an implant funded either. But yeah, I agree. It's often you can view it almost as a first step to the ultimate destination of a penile prosthesis. But not all men want a penile prosthesis.
If I can make a very short final comment, I think that no one will remember a name among those who made contributions in the field of penile surgery in Peyronie's disease in the next 20 years, but because there are just too many. But if there were one single surgeon who would be able to report in a very methodologically sound way the 5-year long-term results of his cases, that name will be remembered. So I think that all of us who are interested in this field should have as an objective not to concentrate too much on surgery in the OR, or at least not only that, but also to follow up patients and being able to have that series, because that name will be remembered forever. Thank you very much.
So Francesco set a good challenge there. Calling now upon Ian Eardley, who needs a little introduction, from St James University Hospital, and Ian's going to tackle the small subject of erectile dysfunction and premature ejaculation in the time available. Good luck, Ian.
Oh, I'll be over and well within the time. This is the front sheet of this year's version of the EU guidelines on male sexual dysfunction, focusing primarily upon erectile dysfunction and premature ejaculation. The EAU guidelines in this area were first published in 2000 and have been updated regularly since, and I've been on the guideline committee since about 2009. I've just demitted, so it's somebody else's job going forward. The 2015 update had a new section on Avanafil. It had been restructured in line with the oncological, with the other non-oncological guidelines, and one of the main drives this year was to reduce the word count by about a third. That's one of the big jobs we had to do this year, to make them far less verbose. There's two main bits, there's an awful lot of text in the EAU guidelines, but there's two bits that really focus what the guidelines say. The first one is there's a series of algorithms, and then there's a series of tables with recommendations, which you've seen in some of the other presentations. This summarises the algorithm for the minimal diagnostic assessment of a man with erectile dysfunction. And it talks about things that I think will be familiar to everybody in the audience. This, I think, reflects fairly standard UK practice. So in terms of the history, you have to identify other problems than the erectile dysfunction that might have caused the ED, identify common causes, identify reversible risk factors, and assess the psychosocial status of the individual. In terms of examination, the guidelines say that we should be examining the prostate, checking for penile deformity, signs of hypogonadism, and assessing in a focused fashion, cardiovascular and neurological status. I think the one comment I'd make at that point is the routine assessment of prostate disease is not something that I do. And just moving briefly on to the investigation, I don't know how many you will have picked up in the recent NICE guidance about diagnosis of cancer that it's recommended that all men presenting with erectile dysfunction should have a PSA test, and that's something perhaps we could debate. Moving on to investigations, the EAU guidelines say that all men should have a total testosterone. That's by far the easiest assessment to measure rather than a free testosterone. They should have a fasting glucose and a lipid profile. And that's what the guidelines say we should do. In terms of specific investigations, they suggest that there are a number of patients who do require specific diagnostic tests, unusual sorts of cases, perhaps not the sorts of cases we see very often. Men who've never had an erection, men who have a history of trauma where you might be looking for a vascular cause. Interestingly, when men have had a penile deformity that might require surgical correction is in the ED guidelines, and that really impinges upon what Roland was just talking about. Men with significant psychiatric problems need a psychiatric assessment. Complex endocrine disorders, I think while most of us would be happy to test testosterone and perhaps for prolactin, if it gets more complicated than that, we'll need an endocrinologist. We've all got the patients who want the tests doing because they want to find the organic reversible cure, and we sometimes do tests for medical legal reasons, and those are all in the guidelines. In terms of the recommendations, the first thing that strikes you about the assessment of a man with ED is how low the level of evidence is for all these recommendations. They're all grades 3 or 4, which is poorly controlled, these uncontrolled studies, cohort studies, or expert recommendation. So the grades of recommendation are really rather poor, and it's rather interesting that largely speaking it reflects what UK practice is. So comprehensive medical and sexual history is needed. Use of validated questionnaires may help to assess specific areas and assess effects of therapy. Examination to identify underlying medical conditions, the routine tests, testosterone, glucose, and a lipid screen, and the specific diagnostic tests are in only a few patients. And that, I think, may reflect a British practice. There is one of the inherent conflicts of the EAU guidelines is that the healthcare systems across Europe are different. In other parts of Europe where there's a fee-for-service system, there's a tendency to do more tests. But that's not what the guidelines say, which are very more goal-orientated and I think largely more in keeping with a British practice. Moving on to the treatment algorithm, in terms of the treatment, the reversible and curable causes should be identified, risk factor modifications should be identified and treated, and obviously patients and partners should be counselled. And then following those three things, the needs of the patient are identified and there's shared decision-making about specific treatments. And in terms of those treatments, in the algorithm, it would appear that the PD5 inhibitors appear to be of equal priority in terms of degree of intervention with other more invasive treatments, intracavernosal injection therapy, pumps, or intraurethral or topical therapy. Topical therapy entered this year. But after that treatment, there's assessment of the therapeutic outcome, and if the treatment has failed, then move on to either one of the other treatments or combination of therapy. And if that fails, then perhaps you end up with the third-line treatment of a penile prosthesis. So, in terms of the recommendations, the table, what you notice here, firstly, is that for those treatments, the level of evidence is stronger. And that, I think, reflects in large part the existence of randomized controlled trials demonstrating efficacy of many of the treatments that we currently use. There is good evidence that lifestyle changes and modifications are beneficial. There is, interestingly, particularly in view of the debate I'm going to have with Francesco later on, a recommendation that pro-erectile treatments have to be given at the earliest opportunity after radical prostatectomy. If a curable cause is found, it should be treated. And then there's a clear statement that PD5 inhibitors are first-line therapy. Inadequate, incorrect prescription and poor patient education are the main causes of lack of response to a PD5 inhibitor, and I think we'd largely agree with that and reflect that in our practice. And then use of second-line treatments, pumps and injections, and penile implant being a last resort, third-line therapy. Moving on to premature ejaculation, again there's an algorithm, and this summarises that algorithm. The clinical diagnosis is based around primarily a history, making the diagnosis with the three prongs of the diagnosis, that is difficulty in control, it's the delay, the intravaginal ejaculatory latency time, and the bother. But then, in the history, it's recommended that the onset and duration should be assessed, psychosocial issues assessed. The bits about the physical examination and the investigations are very poorly documented, and the reality is there's no evidence that physical examination or investigations have any role in the assessment of a man with premature ejaculation, unless you suspect a specific cause such as thyroid disease. Treatment is based around counselling, discussion of options, and if there is coexistence erectile dysfunction, then it's recommended that the ED is treated first before moving on to the premature ejaculation. And then in terms of treatment, pharmacotherapy is recommended as the first-line treatment for those men with lifelong PE. Ideally, dupoxetine, if it's available within your CCG, but off-label SSRIs, which paradoxically are available from most CCGs, are regarded as second-best treatment, even though they're unlicensed. And then also in that column, in the algorithm, is behavioural therapy and combination therapy. Moving on to the recommendations in the table, diagnosis and classification is based upon the medical and sexual history. The history is primary in the assessment of a man with PE. Clinical use of the intravaginal ejaculatory latency time is regarded as being adequate. Use of stopwatches has obvious problems and is not recommended as being necessary for most men, and what the patient tells you is recognised as being reasonably accurate. PROMs may have a role, physical examination may be necessary, routine lab investigations not recommended routinely. In terms of the treatment, these are the levels of evidence supporting the various sorts of treatment. ED to be treated first has a reasonable level of evidence. Pharmacotherapy first-line treatment for lifelong PE, that's what most of the trials show with dupoxetine, and that covers the use of dupoxetine or off-label SSRIs. There is data for local anaesthetic agents, although we don't have any licensed at present, and behavioural therapy has some evidence, but what evidence does exist that suggests it's best used in combination therapy. In terms of the specific treatments, that again is the levels of evidence and the grades of recommendation, with better evidence available for the SSRIs and for the local anaesthetics, and lower levels of evidence for on-demand use of PD5 inhibitors. So what's my commentary on all this? I've really just run through the EAU guidelines. And the reality is it's really very difficult to judge what UK practice really is. Largely speaking, those guidelines reflect my practice, but perhaps they would do, because I was on the committee that agreed them. But I think it is my observation that, largely speaking, they are in line with UK practice. There's been no British guidelines since 2007, and they broadly agree. The BSSM guidelines are largely similar. And if you go and look at the map of medicine or NHS choices, they largely reflect the EAU guidelines. As I've already suggested, it is interesting that those guidelines largely reflect a goal-operated approach to the management of man with ED or premature ejaculation, rather than reflecting the differences in healthcare services and their funding across Europe. Overall, I think it's my view that those guidelines largely mirror UK practice in both the assessment and the treatment of both erectile dysfunction and premature ejaculation, and I think provide a very useful guide to practice in this country. Thank you very much.
As you say, plenty of time for questions. Thank you. Any comments from the floor? Does practice vary between here and Italy, would you say?
we are still seeing a large number of tests being done in urological offices that are not really changing what will be done to that specific patient. I'm thinking about erectile dysfunction, where I still see a large number of penile Doppler studies being done. That is part also of something very peculiar in my country, where the practice there, Chris, would be mainly private. And so clearly there is an interest also from the urologists to do those type of tests.
Okay.
Please, number 2.
I appreciate this may be going on to a different topic, but in terms of erectile dysfunction and treating borderline testosterone, is there any evidence for the 8 to 12 or 10 to 12 group?
There's nothing in the EU guidelines about the testosterone management. The recommendations about 8 to 12 come from a multi-society consensus document that was published, I think, when Francesco was editor of European Urology, and encompasses experts from EAU, AUA, IWSM, and so on. And it's based upon expert opinion, primarily. The evidence base, I think, is limited. The best evidence comes, I think, from a study done by the endocrinologist from Munster, whose name escapes me, where he very clearly demonstrated an association between different levels of testosterone and different sexual symptoms. And that, I think, provides the best evidence base. It's not randomized controlled trials on any level.
Ian, is now in the UK, are all the PD5 inhibitors approved so that you can prescribe whatever you want?
They're all approved, but you certainly can't prescribe whatever you want. Since sildenafil lost its patent, the price went down, and the NHS changed the prescribing regulations so that all men are now entitled to receive generic sildenafil from their general practitioner without having to seek secondary care. So that's available on the NHS, reimbursed up to about 1, perhaps 2 tablets a week for some people. We have a commissioning system in this country run by things called CCGs, clinical commissioning groups, and they have taken a varied view to what to do with second-line therapies. Many of them, as I think we heard this morning in one of the presentations, have gone for Avanafil as the recommended second-line treatment because it's cheaper than the others. It's less expensive, and so the CCGs have made that recommendation purely on the basis of cost. You and I know that Avanafil is really very, very similar to sildenafil, and so one could debate that.
We had an excellent presentation earlier from Michael Fraser, and certainly you've touched on the guidelines. Now, the guidelines always lag behind the cutting face. Do you see anything on the cutting face at present?
The things that I think we've got to look at, Mike was a bit dismissive of shockwave therapy. I think there is some good data there from good units suggesting that it might be beneficial. The difficulty is all the good data comes from a single unit. I think we need to see other units reproducing that sort of data. And we need also to, having had one machine with data, if you go around the exhibition, there's about 3 different machines out there. And I think whether they are all the same, whether they all have the same efficacy, I think is yet very debatable. But shockwave therapy might come along.
Thank you very much, Ian.
So the next guideline that will be discussed is the one about male infertility, and Mr. Jonathan Ramsey from Charing Cross Hospital is going to discuss that for us. Thank you very much.
Good. Well, thank you very much for the invitation. And it's good to see quite a few people here, more each year, which must be a good sign. So, the thing about guidelines must be that if you apply them, you get some kind of result. And of course, that is exceedingly difficult in matters of male infertility. There is evidence, however, for IVF and ICSI. There is evidence for hypogonadotrophic hypogonadism, in which using gonadotrophins usually stimulates spermatogenesis. But with the exception of those 2, one intervention and one treatment, we cannot relate any treatments that might derive from the guidelines to an outcome. This makes the whole issue exceedingly difficult, particularly in a unified or almost unified National Health Service, where socialized medicine has an awful lot of connotations, both political and financial. So, as was famously once remarked, when you're trying to solve a problem, follow the money. The money is with IVF treatments. This is the currency of so-called fertility treatments, of course, in fact, really rather confused with fertility solutions. For the IVF ICSI procedure doesn't provide any treatment whatsoever for the man. And the guidelines that exist for UK practice have come from the College of Gynecologists, and these actually are about preparation for assisted reproductive technology. They are not really about investigation. They're investigative tests, yes, but they are not aimed at any treatment, but rather for being able to provide what is thought to be the solution. Now, the second enormous problem is that a guideline does exist for treating infertile couples, and it exists for couples, not individuals. And this actually is why those men who arguably should be seeing urologists, who should have a treatment guideline applied to them, are nowhere near a urologist, because of course the currency for their treatment lies exclusively with the gynecologist. This is not their fault. It's the way it has happened with good intentions in a nationalized, socialized medical system. I'm not going to read this out, but this is what happens. This is what happens in fertility units up and down the country. So that, I'm afraid, is the way the interview goes. Note that the male patient, as we all know, is never examined by a gynecologist. Rarely, there are a few who do, but mostly not. And certainly not investigated for those important aspects that relate to male health, and particularly the development of the metabolic syndrome. The other interesting philosophical point here is that the poor, desperate couple who will do almost anything to achieve a pregnancy and a baby are impressed by the success of IVF and ICSI. But if you stand back from this and you look at an intervention which succeeds at best in 35% per cycle, at best, and nationally less, and you say, so does this intervention work? Apply it to any other intervention? The answer is not yes, it's no. So we're really behaving in a slightly aberrant way as doctors before we even begin. So the interview continues. And that is a very, very cogent point. Because in order to justify this intervention, then clearly the answer to that question has to be this. So it may well happen that attempts at natural intercourse fail. They cease. So we're out of the loop before anything has ever been done. And then there's usually a gap whilst these people are treated. And depending upon where they are, they will have a variable number of treatments, depending upon their resources and the resources of the local health economy. So this is the male patient. At the end of the road. So, we need to try to change this. We can only change it, of course, if we get to the patients. And I would suggest we can only change it if we begin to understand the basic investigation, which is semen analysis. I'm not sure whether you can see this, but this was the same patient, different places, both reputable places, a reputable fertility unit on the left, a reputable diagnostic lab on the right. Of course, what had happened here was that the poor man had refrained from ejaculation on the left-hand side of the slide here for 4 weeks, and then the first bit of the ejaculate had been missed. And so in the same week we have this wide variation, a very simple explanation. But huge variations between laboratories, between observers, and within individuals. And so we need to understand the qualitative values of the basic investigative tool for urology. And of course, the vast majority of semen analyses are being done in fertility units. In our local trusts, the vast majority of semen analyses are done to determine whether or not vasectomy has succeeded, or as a pretty basic diagnostic investigation. Now, some of the variations have been admitted by ourselves. On the left side there are the 4 iterations of the WHO parameters defined mostly by committee, and then on the right the currently used standards, which completely differently were derived from 1,700 couples whose fertility was proven in 1 year. Now, if you look at the red columns, then those can either be used to tell a patient that actually, with these numbers, fertility is possible, or, of course, they can be used conversely to justify IVF. So we have to be very careful with these numbers and try and understand them. Now, you need a very long memory or to be terribly ancient to remember what happened before ICSI. ICSI has been, or was at the time, a revolutionary treatment for male fertility, 1992, 1993. So there's not much information before that. The Canadian study on the left-hand side of the screen was published in 1983 and shows what happens in the untreated state. And you'll see that sperm densities of around about 9 million were associated with a 20% cumulative pregnancy rate over the next 36 months. Now, I say this merely to indicate that possibly the results from IVF-ICSI are not quite so, in inverted commas, good as they might be, as there is an underlying natural conception rate, which was reiterated in the Walcheren study of 1997, only 3 or 4 years after ICSI started. So, these are the RCOG guidelines, and this really is what is happening, if we are honest, to the male patients whom we may or may not see who yet have been to a fertility unit, because NICE says that couples must be seen together. So this is what's happening. And it's quite a lot of nothing, as you will see. They pick out the hypogonadotrophic hypogonads, and they go to an endocrinologist. Carrier type is recommended, the abnormal carrier type, well, that's okay. That goes for counseling, and it is admitted that many of those, of course, will be Klinefelters, and they'll need testosterone replacement. CFTR positivity implies to the gynecologists absence of the VAS. Well, of course, having not examined them, then it may well imply that, but it may well not. Interestingly, the guideline does give us urologists a little chink of opportunity there. There is no mention at all of physical examination. Compare this with the European guidelines, which have been regularly updated, and there are extremely important and cogent points here. I needn't read them out, but a diagnosis being mandatory is clearly very important, and from the foregoing it is quite evident that such a diagnosis will never be possible on the basis of the current Royal College of Gynecologists guidelines. The Y microdeletion is interesting in the light of Sucks's very interesting work later to be revealed in one of the poster sessions. I think Sucks and his group found that Y microdeletion was a very rare event and was suggesting a lower sperm density as a threshold. I must say that's my own anecdotal observation. But these guidelines are good. They're great. They're fine. They've been modified frequently, updated, make sense, and are clearly the right thing to do. So in summary, we need to get into those fertility units. I don't think we'll change the NICE guidelines for the College of Gynecologists. This is not wickedness, but treatment, that is a solution, is in the hands of the gynecologist whilst the infertile couple need to be seen together. Because we certainly can't do what the gynecologists do, but they, through their guidelines, imply that they can do what we can do, which clearly isn't right. So we need to get into those units. We need to be nice, helpful. We need to understand the meaning of a diagnostic semen analysis and not merely to follow the lead from laboratories which are principally concerned with endocrinology, with embryology. Thank you very much.
Are there any questions? We have time for one or two short questions from the audience, please. Microphone 2.
Thank you very much, Jonathan. There is a little bit of change because the NICE quality standards have said that all men should be assessed. They don't stipulate whether by a gynecologist or a urologist. But we are in a little bit of difficulty because you can only make the quality standard based on the NICE guidelines to begin with. So if something's not in the NICE guideline, you can't just incorporate it. So we're stuck in a bit of a corner. If we don't, get involved with the NICE guidelines, you can't then do anything later on. So there's a little bit of a change. But again, I agree, probably not enough.
Yeah, but I think I totally agree, Asif. Thank you. That's a very useful change because if we can get into those fertility units, and this is the key, then most of our colleagues, gynecologists, as we know, they're not really, they didn't sign up for examining the scrotum. And to have us next door saying, don't worry about that, we'll do it, I think we can begin to change it from within.
Are there private fertility units in the country? And if so, is there a different organization in the private sector?
No. No, it's a very interesting question. Do some private units involve urologists more? Yes, they do. Some. But some resolutely do not. Because, of course, to be cynical about it, all we can do is to delay the time at which the treatment can commence. And we wouldn't want to imply that somebody could make the bloke more fertile. I mean, this would be a great, great error. Might have to buy a motor car with a shorter bonnet.
Thank you, Jonathan.
Thank you very much.
Hey, last but not least, we're coming on to the important subject of penile cancer. And, of course, Nick Watkin is a real expert on this from St George's Hospital in London. Nick.
Chairman, ladies and gentlemen, thank you very much. So we've talked about guidelines a lot already, and I'm just going to remind you what international guidelines exist on penile cancer. And, of course, no prizes for guessing that the EAU guidelines come out first in this. First written in the year 2000 and updated every 5 years as a major update, right up to last year and recently published. And I would echo Ian's comment about being involved with the guidelines. It's a lot of work, it's a lot of commitment, and it does seem to generate progress. And I think That's been reflected in the fact that the EAU guidelines have largely been co-opted by other guidelines used around the world, and I would include the ESMO guidelines in this, for which I was involved with, but we lent heavily on the EAU experience. The AUA are quite open about the fact that they have simply adopted the EAU guidelines with some local modifications. And there's a group in the States, which is a large group of cancer centers, the National Comprehensive Clinical Cancer Networks, which have essentially also adopted the EAU guidelines and rebadged them. So the EAU guidelines have very much been the mainstay of the evidence base for the penile cancer management. But what is the quality of evidence really like? Well, there's no doubt there has been an increased incidence and perhaps awareness of management of penile cancer over the last 20 years. I'm not entirely sure why that is per se, but people do seem to be more alert to it. But if you look at the PubMed publications, there has been an exponential rise in publications. Back in '94, there were just 80 papers on the subject. 10 years later, it was 140, and last year it was 220. So some genuine increase in interest. But what about the levels of evidence that interest has generated? Well, there is no level 1 evidence in the world literature at all. Depending on your perspective of what level 2 evidence actually is, and you can, depending on your paper or whether it's someone else's paper, call it level 2 or level 3 evidence, somewhere between 1 and 30 papers might constitute level 2 evidence for treatment. But there are over 5,000 papers with level 3 or level 4 evidence. So on that basis, how much work goes into the guideline to generate what we know? Well, we update it every 5 years, as I mentioned. And for 2014, we looked at, in the end, 352 papers over a 5-year period, which were new to the subject, having whittle that down from 1,600 abstracts. And it took about a year of regular work with the committee to generate the most recent guideline. But is it actually worth it? Because you could say there's just no good evidence and go home. So what about UK practice? Well, we have moved on from where we were at perhaps in the year 2000. England and Wales have genuinely centralized services into 10 centres, very similar but not quite so centralized in Scotland and Northern Ireland, broadly following the traditional cancer networks that were in existence. And each of these networks is required to have their own network guidelines, and each of them is required to review them annually in order to submit their evidence to peer review. And mostly they are based on the EAU guidelines. Some actually even go as far as to say we follow the EAU guideline, and that's their evidence. But basically it's largely derived from the EAU evidence. But what are the principal differences between British practice in those centres and the European guideline? Well, in Europe, what happens, you can basically have any local therapy, because as there's no evidence to contradict any treatment that's ever existed, as the evidence has increased, you simply add new techniques to the long list of possible treatments. So any local therapy, from radiotherapy, laser, various surgical practices, Mohs micrographic surgery, all these are acceptable in certain situations. In treating more advanced patients, there's quite a strong recommendation about neoadjuvant chemotherapy for bulky nodal disease, and even adjuvant chemotherapy for quite advanced nodal disease. But in a slightly contradictory way, adjuvant radiotherapy for nodal disease is actually not recommended, which, again, is quite a controversial statement. In UK practice, we're more inclined to offer some form of penile preserving operation, and that's probably because the networks are largely dominated by surgeons, but it's still probably a more consistent practice in the UK. Not many centres will offer neoadjuvant chemotherapy as part of their practice, although some say they do in selected cases. And very few oncologists will offer adjuvant chemotherapy to their patients in advanced disease. But on the other hand, quite a lot of centres will practice adjuvant or even palliative radiotherapy for certain patients quite commonly. So quite different, despite the European guideline being allegedly the font of all knowledge. So what can we do to improve the quality of the evidence that we have and hence the quality of the guideline? Well, one thing's for sure, it doesn't matter how hard you look at the literature and do your own literature search and reanalyze it, you still come up with the same conclusion, that it's rare and that the quality of the evidence is relatively poor. But we do have the option in this country and more recently in Denmark and Sweden and Holland of centralization of services and collaboration across different countries. And that will be, I think, the opportunity in the future to try and answer some of the questions about the more advanced patients. Indeed, in October this year, after 5 or 6 years of hard graft, the International Rare Cancer Initiative penile cancer trial is just about to start. And essentially, this is a trial which is looking at the group of patients who have high-risk nodal disease, essentially, for whom inguinal nodal surgery may or may not be combined with neoadjuvant chemotherapy or neoadjuvant chemoradiotherapy, and a second randomization looking at pelvic nodal surgery versus observation. It's a complex trial. It's got centres in US, Canada, Europe. Most of the UK networks have signed up to this, and we finally pressing the go button in October this year. That's the randomization for the pelvis. And does centralization in this country and others bring additional benefits? Well, I don't think we can ever really go away from clinical experience. We're quite heavily into guidelines and following guidelines, but in rare diseases, I think there's still a case for the experienced surgeon or clinician or oncologist who says, I've seen that before, or we've seen this 30 times before over the last 20 years. I don't think we should ever go away from the fact that if you can't, just because you can't prove something is evidence-based, that the knowledge and experience of the clinicians doesn't count for anything. And in fact, I think the evidence sometimes is that the clinician's knowledge is stronger than the clinical evidence that's actually published. So just a final thought. Who reads the European guidelines? Because they are downloaded frequently. European Urology loves the guidelines because they're cited frequently. So it's the exam candidates, it's the FIBU candidates, it's the FRCS Urol candidates, it's the examiners who are going to the FRCS Urol who want to mug up on the guidelines. It's the clinicians in this country and others who are preparing their local or national guidelines so that they can adapt them, plagiarize them, borrow them, whatever you will, to make their own life a bit easier. But it's actually also all the sole practitioners around the world justifying their own experience of treating one patient to the lawyer when it goes wrong. Provided they've followed the guidelines and they've done the best that they can, that's fine. And surely that's not really the practice that we should be encouraging. We all feel that centralization of rare services is a good thing. You may not be able to prove it scientifically, but I think instinctively we believe that. So perhaps when we come around to the next update of the penile cancer guidelines in 2019, there won't be a problem making it reduced in word count. Ian's pointed that out already. It should be one page. Recommendation 1, any urologist should learn how to recognize a penile cancer. Recommendation 2, every urologist should refer to a specialist centre with an established and printed out, agreed multidisciplinary guideline for the treatment. Thank you very much.
Time, Nick, for a few comments or questions. Anybody want to?
I have
Jessica.
one question. I think you gave a wonderful presentation. In my country, if the process of centralization did start, we don't have that yet. There would be many urologists angry against that because they would fear of losing business.
Of course.
And there would be lots of citizens being angry because they would say, well, why should I drive 100 miles if I have a nice small hospital next to me where I am sure they can treat my penile cancer very well? What is the situation here in the UK from the eyes of the citizens, of the patients?
Well, I can only comment on our own practice, and we have patients coming up. The furthest distance is about 180 miles, and you have to remember that patients can be anything from 25 to 105 years old. Actually, they like it. They like to feel that they've gone somewhere to see someone or some team that cares about them and actually is going to treat them according to some best practice. They often don't mind what the practice is. They just think it's the best practice. And even with follow-up, most patients want to come back and see you, even though it's probably not necessary on most occasions. So our experience is very positive. The clinic is very enjoyable.
Yeah. Very good.
It's part of a wider picture in the UK, isn't it, with centralisation of cancer services. So it's accepted practice now, so people fit in with it. Any other comments? Well, I think it's been... Thank you very much, Nick.
Okay, thank you.
I think it's been a very interesting session with five of our national experts dealing with topics, looking at the evidence base, and it's noteworthy that I think it's true to say, isn't it, that BAUS have acknowledged and accredited the EAU guidelines over the last few weeks, so that's great. And I think that also, certainly penile cancer, BAUS are looking at this being one of the subjects for reference network submission to the European Union, which is also coming up. We've heard from the various talks that the guidelines deal with what's acknowledged practice. There's clearly various new developments in the field, and obviously we're going to see more about this in the years to come. So thank you very much, everybody.